Good morning, good afternoon, or good evening. On behalf of Oman Ophthalmological Society, I, Dr. Deshmukh, along with Dr. Shihab, welcome you all to another exciting day of MIOC. I'm quite honored to introduce our first speaker. He actually needs no introduction, Dr. Arup Chakrabarti. He's a senior consultant and director of Chakrabarti Eye Center in Trivandrum. He is present editor proceedings of prestigious All India Ophthalmological Society. He is also an editorial committee member of IGO. He is presently president of Kerala Society of Ophthalmic Surgeons. His field of interest, of course, is complex cataract surgeries. He has conducted 210 instruction courses as a chief instructor in prestigious international meetings, including ASCUS, AO, as well as AIOS. He has been elected as a member of highly prestigious and exclusive International Intraocular Implant Club in 2015. He has edited 3 books. He is also a reviewer for prestigious journals, including JCRS, IGO, BMJ, as well as AJO. He has given more than 1,500 presentations as faculty for workshop and instruction courses in various national and international conferences. He has more than 76 publications in peer-reviewed and international journals and presented 107 free papers, 22 posters, and 111 videos. I can go on like this, but due to paucity of time, I would just request him to start his presentation. So welcome, Dr. Arup.
Am I visible?
Yes.
So good afternoon to you all, dear friends. I am Arup Chakrabarti from India. And thank you, Devdutt, for the very kind introduction. And I'm really honored to be participating in this symposium titled Challenges in Cataract Surgery, organized by Oman Ophthalmological Club. I have nothing financial in whatever I'm going to talk to you on the topic allotted to me, that is overcoming ultra-hard cataract challenges. My presentation is basically going to be a series of minimally edited videos, and I have been tackling these cases for the last 25 to 30 years. I've evolved a technique, rather a variety of techniques which are user-friendly, reproducible, with minimal intraoperative complications and overall good long-term outcomes. So favorable outcomes with these challenging cases depend upon self-belief and preoperative surgical planning, which includes the various strategies for nucleus disassembly and appropriate control of the intraocular environment when the nucleus disassembly is happening. Now, the nucleus disassembly usually progresses in 3 stages for these hard cataracts: debulking the size of the nucleus, and then dismantle or fragment the nucleus, and finally consumption of the fragments. In certain situations where the cataract is not very hard, or if it is hard but still brittle, you can bypass the first stage of debulking and you can straight away go to dismantling and fragment consumption. So let us see some of the techniques which I have been using with very good results over the last so many years. This is not exactly a very hard cataract, but this brings out the basic strategy that I employ for my chopping hard cataract situations. Now make a triangle, sculpt a triangle with the apex based on the incision, as you see here. The nasal wall is pretty deep. Use high vacuum and a little high flow rate to impel at the depth of the nucleus, and then use a chopper. It could be Sinskey hook, it could be a standard vertical chopper or a Chang chopper, and develop a cleavage line. What I'm doing is a diagonal chopping. So I see the cleavage line starting from the periphery, and I try to bring it to the center. It is not always necessary that the entire nucleus will be split into 2 halves by one chopping maneuver, That is not necessary because at times it may be too traumatic. It is also possible what you see me do here is develop a chop line in the periphery, bring it to the center by chopping in situ and do it in a step-by-step manner till the chop line comes centrally. And then when the chop lines of individual pieces join at the center, you have isolated pieces of nucleus that have to be consumed during the fragment removal stage. Now, the number of pieces of nucleus that a fragment, the whole bulk, whole mass into depends upon the size of the nucleus and the size of the rhexis. If I'm dealing with a supra hard cataract with a very small rhexis, I like to get somewhere between 8 or 10 pieces of nucleus, bits of nucleus, fragments of nucleus. Otherwise, the manipulations inside the bag may become very hazardous and it may be traumatic to the zonules. So this is basically the nutshell, in a nutshell of the technique that I follow. Now, this is a hard cataract. So here, I would employ a different strategy where I have done a short, deep central groove and impale the phaco tip at the depth of the groove of the distal wall or the nasal wall, and using the Chang chopper, which is about 2 millimeters in length. So initial chopping maneuver did not succeed. So I went inside again, buried my tip little deeper into the substance of the nucleus. Chop developed in the periphery and I brought it to the center. It did not travel across the entire length of the nucleus. As I mentioned earlier, that may not be really necessary. And then when I rotated the nucleus, I made sure that the chop line which develops right now joins the previous one, so that you ultimately have all those bits of all the big mass of nucleus divided into multiple small pieces. Here, I'm just focusing on how to chop the nucleus. Fragment consumption, of course, requires a different phaco parameter settings, and I'll be coming to you at a later stage. When you chop the final stage, a final chunk of the nucleus, one has to be careful, because this is a time where if you're not careful, occlusion surge, the post-occlusion surge may occur, and this may jeopardize the posterior capsule. Now, this is another hardish cataract. So here I'm going to use a little different strategy, and I think this is a strategy that can be employed by any surgeon for any degree of hard cataract. So first step is all the OVD that is placed in the anterior chamber just in front of the nucleus, particularly if it is viscoat or Hilon GV. It has to be aspirated from in front of the nucleus surface and then start sculpting. So here, I'm using a torsional phaco, and I've kept a phaco power at about 80%. Make sure that the groove or the tunnel that you make, the trench that you make is pretty deep as possible, as close to the posterior nucleus plate as possible. And we also try to shave a little bit of the side wall of the tunnel so that there is proper access of the phaco sleeve and the phaco tip combo as you start chopping. Now, this is the nasal wall of the trench, and I have now converted. I'm no longer using torsional, I'm using longitudinal, impale into the substance of the nucleus, and then chop. Let us see in the slow motion here. It is just the Sinski hook that I'm using. It is an oblique chopping. It's not a karate or a chopping as such. I go slightly to the periphery near the rhexis margin, little maybe beyond. And then as the two tips approximate, then there is a lateral movement that is made. And you see the chop line that is developed here. And then again, I'm going to rotate it maybe another 30 degrees and repeat the same sequence of steps, manipulations, or maneuvers to get the nucleus into multiple pieces. It goes without saying that you need to replenish the anterior chamber with a good quality dispersive OVD from time to time to ensure that the cornea is well protected and the ions that are generated, they are also absorbed. So there is not much of toxic elements that are there to jeopardize the corneal endothelium. So it is not really necessary for us to use any dedicated chopper as long as you know the surgical principles, you're working with a high vacuum, appropriate flow rate, and appropriate intraocular pressure. Make sure that when you're chopping, there is no disengagement of the nucleus that is held by the tip of the phaco, because in that case, you're going to have a post-occlusion surge. So so when you we have divided the nucleus into a piece, you just come back to position 1, and then so that there is no question of any post-occlusion surge that can happen. So this is the same thing here again. The nucleus has been divided into multiple pieces, and sometimes in certain situations the nucleus may be joined at the center, at the apex. So that actually is not a great disadvantage, because so that prevents the nucleus from migrating anteriorly, and it helps you to keep the nucleus mass of the pieces of the nucleus within the capsular bag and avoid performing phaco close to the corneal endothelium. One got to be very careful with the last piece of the nucleus, because occlusion has to break and then maybe surge if you're not very careful. And sometimes the small chunks of nucleus may also hide in the peripheral anterior chamber in the angle hidden by a thick arcus senilis, or sometimes it may go behind the posterior chamber into the posterior chamber hidden by the iris. So it may reappear on the postoperative period, when again you may have to go in because the patient complains of situations like because of iritis or corneal edema. So the last chunk of nucleus has to be taken up very carefully. Now this is a dense cataract, but this is a brittle cataract. So here I would not be doing much of sculpting, and I'm using a longitudinal phaco here. It is the goiter negative. It has got three slopes that generate phaco power, and the tunnel that you see here at the center of the phaco needle is only 0.5 millimeter. And that is the reason we do not have much surge that has happened associated with this particular machine. So I keep my phaco tip stationary and move my left hand, the Sinskey hue, in a progressive manner, coming from the periphery to the center, till I ensure that the chop line has come to the center. And then again, the same process is repeated. Go into the depth of the nucleus as deep as possible. If you feel that the nucleus has a tendency to rotate, or there is a tendency for the nucleus to get tilted or dislodged, you can use little additional bars of phaco power, go into further depth of the nucleus, so that you have a better hold, better purchase on the nucleus, and then start chopping it. So here again, I'm not, but this was a hypermature cataract. The bag is quite fragile. So I would not like to remove a single piece of nucleus at this stage, because I don't want to jeopardize the posterior capsule. At the same time, I want the bag to be kept filled up until all the nucleus has been broken up into multiple pieces, and I'll be removing the pieces one by one. In certain situations, I would remove the first piece as soon as it is generated. In situations where the capsular bag is very, very congested, it's a huge nucleus, and for some reason or the other, you've got a small rhexis. In that situation, the intercapsular manipulations may become difficult. So you need to create some space by removing a small chunk of the nucleus. So here I'm using a vacuum about 350 to 400, a flow about 50 milliliters per minute, and a bottle height about 60 or 70 centimeters of saline, and a burst mode. I'm using a burst mode here about, pulse mode, 40 pulses per second with a 30% duty cycle. So these are the parameters which give me very good results while I try to chop these hard cataracts using a longitudinal phaco. Next, this is actually an Anglo-Indian lady, an elderly lady with a bilateral black cataract. I operated on both the eyes, and this is the first eye. Let us see how this case was managed. I just want to emphasize that the certain techniques we tend to look down upon. For example, stop and chop technique. This is a technique which got Paul Lescock a grand prize at the ACRS in the early 1990s, and it's still good enough. Now, this particular case, I have decided that I'll use a stop and chop technique. And as you will see here with the CD, it does not really too much. So I remove the OVD just in front of the nucleus. Otherwise, there is a potential for wound burn if you're using Hilon 5 or Hilon GV or Viscode. And then try to go as deep as possible and try to generate the chop line. I would say the crack line at the periphery. Now, as you see a line develops in the periphery, you try to bring it to the center. Move sequentially in a step-by-step manner. And if you feel that there's a lot of lateral separation is required, or you need to use a lot of force, you can always go back and sculpt a little deeper into the posterior nuclear plate. So eventually, with persistence and with self-belief and with the proper technique, you'll be able to divide the hard black nucleus into two pieces, as you see in this particular case. Now, this has been achieved, And subsequently, I'll go for phaco, that is the chopping maneuver here. So, again, a lot of OVD and dispersive OVD has to be replenished into the anterior chamber. Visco, sometimes you end up using a lot of OVD to get a clear cornea in the postoperative period. I have stepped up, I have gone up to a vacuum of almost 700 plus here. And the chopping should be easy for me in this situation because I know at what depth the nucleus can be cracked. And as you see here, the chopping process becomes very, very simple. The phaco handpiece is not moved much. It is only the chopper which is basically moved, and making sure that there's not much of lateral separation. The rhexis does not get distorted. The capsular bag does not get stretched unduly, and all the manipulations are performed within the capsular bag. And so subsequently, you will end up with multiple pieces of nucleus, as you'll see here, small bits of nucleus. There's a small chunk of nucleus that has come up. And as I mentioned earlier, you have to be very careful when you remove the last piece of nucleus, because this is the time where most of the PC events happen in these challenging situations. And sometimes you may even use a visco expression to remove the last chunk of nucleus through the clear corneal incision. So remember to use a lot of OVDs in these situations. Do not want the cornea to be compromised by ricocheting nucleus particles as you remove the last fragments of the nucleus. Now, this is the first postoperative day. The eye is crystal clear, sparkling cornea. Patient had a vision of 6/6, and the fellow eye also had done well. So this is just to highlight that there are certain older techniques which we tend to not use, not promote much. They do extremely well in these hard cataract situations. This is the last case I'm going to show you. This is a case which I did this Tuesday. This was actually a post-macular hole surgery, 3 years. Patient hadn't come, and she returned with a vision of 360. Had an absolutely hard nucleus cataract, and I followed almost the same strategy here. And I have shown you the surgical principles, what I have done, what I did in this particular case in the previous videos. So this is the first postoperative pictures. The patient had a vision of 6/12. Now, before I wind up, I would say that not all cases go on well. There can be complications. For example, this was a hard cataract scenario. Patient had asked for a toric intraocular lens, and I went ahead with the surgery. Rhexis was not small; it was 5 millimeters in size. In hard cataracts, you must do proper hydrodissection. It should be done very gently, because many of these elderly patients, they tend to have a thin, fragile posterior capsule, particularly the elderly woman. So hydrodissection has to be done very carefully. Before you perform hydrodissection, the OVD should be burped out of the anterior chamber. You don't want the pressure in the capsular bag to go up very high. So here things are going on absolutely fine. This is the mega tip. I have chopped with the Chang chopper, and you see the chop line developing the periphery. It is coming to the center, and I'm pretty happy that things are going on extremely well. Well, at one point in time, I realized that I have lost a little bit of control because the nucleus showed a tendency to tilt. The nucleus was showing a vibratory movement. I was not able to rotate it. The followability of the nucleus was not as it was when I started off the chopping maneuver, and it will be very clear right now. See, I am not able to get the nucleus into the phaco tip. It came with a little bit of difficulty, this particular chunk, but if you see the next chunk, here, for example, it doesn't rotate well. And so I smelled trouble. And then I realized that maybe I'm dealing with a posterior capsular rent or a zonular dialysis in this area. So I went inside, used a visco shield strategy, used a viscoat, copious amount of viscoat behind the nucleus, where I thought there could be an area of posterior capsular rent or a zonular dialysis. A little bit of anterior chamber phaco is done in this kind of situation because you don't want to be operating within the capsular bag, because this is the place where the posterior capsule is given way. So you want to be away from the posterior capsule as much as possible. So anterior chamber phaco, anterior level phaco is done. We use a lot of OVDs, dispersive OVDs. So I remove the entire lens matter, and soon it will be clear that I did indeed have a large posterior capsular rent. Now, when you suspect a posterior capsular rent or a zonular dialysis, before removing the phaco handpiece or the education handpiece, inject OVD. So now you see this is large nasal area. There's a D-shaped posterior capsular rent. At what stage it happened, how it happened, I could not figure out. I saw the video several times, and you can see that there is small chunks of dense matter in the anterior vitreous. There's nothing that I need to be doing at this stage. I abandoned my plan of using a toric lens because they come only in single piece platform, and you cannot use a single piece lens in the ciliary sulcus. It is a huge PC lens, so you can't even keep in the bag. So I discussed with the patient that I'm going to change my plan. I'm going to use a standard intraocular lens, a 3-piece hydrophobic acrylic lens. So this was the sensor lens. The leading haptic actually was injected very carefully under the iris, and the trailing haptic. But here I was not sure whether the leading haptic will go through the PC area. So I again brought it up in front of the anterior chamber, in front of the iris in the anterior chamber. And the trailing haptic was compressed and very carefully tucked under the iris in front of the anterior capsule. So I'm sure that I'm in the ciliary sulcus with the trailing haptic. And then the leading haptic also same treatment was given. It was compressed, it was then gently tucked. And the optic was buttonholed through the rhexis because rhexis was about 5 millimeters in size. And postoperatively, this patient had done extremely well, as you see here, had a good vision on the first postoperative day. So friends, in conclusion, I'd like to say that with the proper management of the intraocular environment, as you focus on phacoemulsification and proper use of nucleus management strategy, which I have already discussed in my videos, and incorporate the surgical purse, which I have just discussed, there's no reason that your patients will get a crystal clear cornea most of the time on day 1. Thank you so much for your kind attention.
That were great videos, sir. Yeah, you made it appear so simple, but as focal surgeons, we know it is not that simple. So hats off to you, sir. So let me introduce our next speaker. We'll come to the question answer session at the end. That's better. So I'm happy to welcome again Dr. Rajendra Prasad. He's a familiar figure with us and a great innovator. He's an alumni of prestigious AIMS at New Delhi. He's presently director and senior consultant at RP Center I Institute at Delhi. He has been engaged in continuous research and innovations over the last 35 years and has many publications of his original work in national and international conferences. His innovations include terminal chop technique, which he showed us last year. Then sewing needle microcapsulotomy, which he will be speaking today. Then he has innovations like terminator at wedge tool, hydrodissect for the PPC, and even the T-soft for a soft cataract. He has been awarded National Innovator Award in 2018 by IMA. He's a great speaker. He has numerous paper presentations, instruction courses at ASCRS, and other prestigious bodies. So welcome, sir, and over to you.
Thank you, Dr. Naik, for the nice introduction, and it's really a great pleasure to be with MIOC, because I've been with this now for I think this is the second or third time I'm. Sorry, just okay. Can you see my presentation here? No.
Yes, sir.
It's okay.
Yeah.
So thank you very much. And the topic which I'm going to talk about is okay. I'm going to talk about saving needle microcapsulotomy. This is one of the new technique we have brought in to tackle with the intumescent white cataract. We have no financial interest in the subject matter of this presentation. Friends, we know that these intumescent white cataracts have always been a challenge to all of us, a surgical challenge. Now, the reason for the challenge is because most of these cases have a very high intraventricular pressure, which could be because of the hyperhydrated fluffy cortex in intumescent soft immature white cataract. It could be because of the swollen and flocculent cortex. It could be because of many times because of the partial cortical liquefaction, which we come across in intumescent hypermature white cataracts. And many times we have a total cortical liquefaction and fluid-filled nuclear, the capsular bag with the sunk dense hard nucleus. In Morgagnian white cataract also we have a high interlenticular pressure. And most of these cases are coupled with very thin and fragile capsular bag because of the liquefaction of the cortex and epinucleus. So you do not have much support of the cortex and the cortex and the epinucleus for the capsular bag. And this can be confirmed by the OCT images you can see here, because hyperhydrated the lens, swollen lens, and because there is a high pressure and high volume in the capsular bag, so you have a very tense and stretched out capsule. The anterior capsule, you can see it's protruding into the anterior chamber. There's very shallow anterior chamber. This is what happens with these intumescent white cataracts. And the biggest challenge, or the most critical challenge in these cases, is to get a complete and successful capsular access. So this is the biggest problem with these cases, because the nucleus generally is not very hard. So the nucleus management is not a problem, but you have to get a good capsular access in these cases. So that is the biggest challenge. And here I'm just showing you these two videos where one on the left side, it's an intumescent hypermature white cataract. On the right side, it's a mature white cataract. So the most important point in these cases is you need to stain the anterior capsule. And after staining, you need to start with a little smaller axis in the beginning itself, so that you do not have the chances of extension to the periphery. So keep it a little smaller. And you have to keep a watch on the progression of the axis. Because the axis, as you know, it's an all visual impression, because you do not get the feedback of the axis, how the axis is moving. So you have to keep watch on it and control it with the visual impression and complete the axis. So this can happen, like most of the time we get this kind of axis, but many times then we are not so lucky and we get into this kind of problem. Like when you start the axis, if you have a very high volume the cortical matter in the capsular bag, and you have a high interlenticular pressure, it could be moderate or very extremely high interlenticular pressure. And when you start the axis edge always tend to go to the periphery, and this is what happens in many of the situations. So your axis goes from the periphery, axis extension, and this becomes a problem to complete the surgery. But many times, what happens, if you have a very extremely high interlenticular pressure because of the high volume fluid of the cortex, the moment you puncture the anterior capsule with the needle or the capsular access forceps, the cut or the linear cut which we create on the anterior capsule tends to extend to the periphery. And this happens spontaneously and uncontrollable, because you can't control. The moment you prick, the cut extend to the periphery, it opens up and cut extend to the periphery, and results in this kind of the radial extension, the complete radial extension of the anterior capsular tear. Now, this situation has been described as a Argentinian flag sign by the Daniel Perrone in 2000. And this is basically because the similarity, we can see the similarity of the tear with their flag. So that is why it is called as Argentinian flag sign. And Perrone described it to be the sequelae of raised interlenticular pressure. So this is very right, but the only problem is because he said this is the only factor which is responsible for the progression of the initial prick into the radial capsular tear. And later on, one more theory was added to this, that is called as a pressurized lenticular compartment system, where you have a posterior and anterior compartment because of the partial liquefaction of the cortex, and you have a high pressure anterior compartment. And when you suddenly open up this anterior capsule with the needle or the axis forceps, so what happens? This posterior compartment start pushing the nucleus forward, and there is a forward thrust of the nucleus which hits on the back of the capsule, and this is the reason why the initial cut which is created on the anterior capsule opens up and tends to extend to the periphery and results into the Argentinian flag sign. So various innovations have been taken place to tackle or to neutralize the raised intralenticulaar pressure in these intumescent white cataracts. And some of these techniques like mini Raxis or one-stage spiral CCC or two-stage spiral CCC, they work very well when there is a moderately high intralenticular pressure. You do not have very extreme intralenticular pressure and moderately high intralenticular pressure. So these techniques, they work definitely because you start with a very small Raxis, mini Raxis, and then you can spiral it out, slowly spiral it out and increase the size of the Raxis of around 5.5 to 6 millimeter of size. But you start from the center with a very small Raxis. On the left side, it's a one-stage spiral CCC. But on the right side, what we do is we create a mini Raxis initially, and then decompress the capsular bag by removing some of the cortex and the fluid out of the capsular bag. And then later on, that restart the Raxis by giving a nick on one of the edge of the Raxis which we have created earlier. And then we can slowly enlarge the Raxis to a larger size. So but these techniques, they work very well if you have a moderately high intralenticular pressure, and you can get into the complete Raxis and a successful Raxis. Similarly, the small needle aspiration technique, which is very commonly practiced technique now these days, and also work very well if you have a moderately high intralenticular pressure. But what happens, see this video here, because if you have a very high intralenticular pressure, then the moment you prick the anterior capsule with the needle, the tear which is created on the anterior capsule starts extending to the periphery, even before we initiate the aspiration of the liquid cortex. So what happens, because you are not able to aspirate the liquid from the capsular bag, the capsular tear which is created by the needle starts extending. So that is the reason, like, this technique also works well if you have a moderately high intralenticular pressure. But if you have a very severe or very extremely high intralenticular pressure, this technique will not work and you get into the problem of the Argentinian flag sign. So incidents have been put around 3.85 to 28.3% in the intumescent white cataract extension of the capsular tear. But what is of the tear which extend to the periphery, it goes into the posterior capsule and transform into the posterior capsular tear. So which could result into a serious complication we all know. So it's very important, like, you do not let the capsular tear to extend to the periphery. Otherwise, the surgical complication is inevitable. So that is the reason, like, why the question arises: why do many of these innovative techniques to neutralize the raised intralenticular pressure do not work? And the problem of the radial extension of the capsular tear continues to be a challenge in the intumescent white cataract. It means there had to be some other factors responsible which assist the raised intralenticular pressure to propagate the splitting of the capsular tear after the initial prick. So why the initial prick extend to the periphery? This is what we need to look into. And the saving needle microcapsulotomy to avert Argentinian flag sign, which we have published in JCRS recently. And according to this paper, in reality, it's not the raised intralenticular pressure, the only factor which is responsible for the extension of the tear. So what we have found, it is the configuration of the initial prick, which is created to open up the anterior capsule by the sharp tip hypodermic needle or the Raxis forceps, which is the mainly responsible for the extension of the capsular tear. The kind of opening you make on the anterior capsule is very, very important. And on retrospective examination of the surgical videos, which where we have seen the Argentinian flag sign, what we have noticed that puncturing the anterior capsule with the ultra-sharp beveled hypodermic needle, cystotome, or sharp tip Raxis forceps, it results into a small linear cut with the open edges along the entry of the needle. So you can see here, if you puncture the anterior capsule with this kind of needle, you are actually making a linear cut on the anterior capsule. Now this linear cut has open edges on both the sides. It's not circular, it has open edges on both the sides. This is how it looks like, the linear cut configuration. And you know that there's a raised intralenticular pressure. And when you puncture the anterior capsule, there would be a volcanic eruption of the intralenticular fluid also. Now these two forces triggers a disruptive force which acts along the open edges of this linear cut. And since the pressure is very high and you have a open edges, this linear cut easily opens up and is split along its open edges. And it rapidly radializes to the periphery and results into the Argentinian flag sign. This is what happens actually when you come across with the Argentinian flag sign. So we also found that the tear always extends along the open edges of the linear cut. It never extends perpendicular to the tear cut where the cut is regular. So it means it confirms that something has to do with this open edges of the linear cut which is produced on the anterior capsule. So we came up with a hypothesis that if an opening with a round and regular configuration is created on the anterior capsule, instead of a linear cut, we can prevent the formation of the Argentinian flag sign in these cases. And for that, we just developed a device which is called the saving needle microcapsulotome. Now this has a round and pointed tip, like a saving needle, unlike the needle which has a sharp edge. So this has a round and pointed tip. And if you puncture the anterior capsule with this round and pointed tip, you'll get a hole formation in the anterior capsule instead of a linear cut. And this hole actually has a much better resistance against these forces, because if you have a hole, if the hole is continuous, so this will not suddenly open up and disrupt as the linear cut would open up. We can simply use a simple saving needle also, and just bend the tip. You can use it as a saving needle microcapsulotome to puncture the anterior capsule. This is what you can see here, the hole created by the saving needle microcapsulotome, and this is the cut created by the needle. And once you create the hole, in this video, you can see here, I'm going through with the saving needle only, a simple saving needle, and puncturing the anterior capsule. The moment you puncture, you'll get an eruption of the fluid from the capsular bag, because this had a very high interlenticular pressure. Now, this fluid would decompress the capsular bag, and you can use the visco needle also to further decompress it and do the movement, the pending movement of this needle on the anterior capsule. So you can see here now the capsular bag is completely decompressed and the anterior capsule is almost flattened. So you can now very easily start the rhexis and complete the capsular rhexis. You can make a single capsulotomy, microcapsulotomy, but if you have a multiple fluid pockets, we can make multiple microcapsulotomy also to completely decompress the capsular bag. And before we start the microcapsulotomy, in these cases, it's always better to use a highly cohesive viscoelastic to flatten the anterior capsule. And if you have a high interlenticular pressure along with high intraocular pressure also, then we can use preoperative mannitol, or posterior decompression is done in some of the cases like phacomorphic glaucoma or so. And to start the rhexis, as I told you in the beginning itself, now this is a completely swollen intumescent cataract where there was a very high interlenticular pressure. Stain the anterior capsule, flatten the anterior chamber or anterior capsule with the viscoelastic. And now this is the microcapsulotome being used. And this is a different case where also there is a high interlenticular pressure. You can see the fluid which is coming out of the capsular bag. And this actually makes the evacuate the fluid and completely evacuate the fluid and makes the capsular bag decompress. And then you can further decompress it completely. And once the capsular bag is completely decompressed, you can start the rhexis from that hole itself. You can see the hole here, and just make it tear now. Now you don't have to worry because the capsular bag is now completely decompressed. And then you can start the capsular rhexis of your choice, like the size. You can make around 5.5 to 6 millimeter of size, whichever size is suitable for the particular case. And once you complete the rhexis, and then you can go ahead with the emulsification of the nuclear matter. So to conclude, in intumescent white cataract, it is primarily the linear cut configuration of the initial prick, which is made by the sharp hypodermic needle on the anterior capsule, which has the potential to spontaneously extend along its open edges aided by the raised intraventricular pressure, leading to Argentinian plaque sign. The technique of saving needle microcapsulotomy creates an opening in the anterior capsule, which has a round and regular configuration, like a capsulotomy in true sense, that provides resistance against the disruptive forces, which is triggered by the high intraventricular pressure, thus preventing the Argentinian plaque sign. So initial decompression, when we prick the anterior capsule, initial decompression of the capsular bag facilitates the safe and controlled creation of the capsular axis of desired size with higher level of efficacy and safety. So we do not get the Argentinian plaque sign in most of the cases, and if we use this technique. Literature, and thank you very much.
That's a great innovation, sir. It's a simple modification, but it seems it works well. So it's great. Is it? Are you using the normal sewing needle, or you have made some commercially available option?
Yeah.
I mean.
Yeah, as I showed both the saving needle microcapsulotome, we have made it commercially available also. That is called as a saving needle microcapsulotome. It's being marketed by Epsilon. And but to make it more simpler, instead of the device, you can use the saving needle also, a simple saving needle. Saving needle, you just have to hold it with the forceps and bend the tip a millimeter. Tip has to be bent, and then you can use it to prick the anterior capsule. So it's basically, the idea is to prick the anterior capsule with the saving needle so that you make a hole. You don't cut the anterior capsule.
Right.
And if you cut the anterior capsule, you know that cut has a open edges and it opens up suddenly because of the high intraventricular pressure and the tear extend to the periphery. If you make a hole, it will never extend, because in my experience till now, none of the cases had extended to the periphery if I'm using the saving needle microcapsulotome.
Okay, that's great.
What is the size of the needle? It's very small. Is it enough for the liquid to?
Yeah, actually these needles which are available in the market, the saving needle, they are available with the gauge only. So we can use 18 gauge or 19 gauge needle. Like we use the 18 gauge phaco tip, but here the most important point is the tip has to be sharp. It should not be blunt. If the tip is blunt and if you try to prick, then the capsule will disrupt. You are not able to make the hole. These capsules are very, very fragile, and if you try to push it without having a sharp needle, then it will disrupt the capsule. It has to be sharp so that it pricks properly. So you have to make a hole, and the simple needle can be used. That's very simple, like simple needle, 2 rupees needle. So you don't need to have this the other techniques like femtosecond or so many things for the soft cataract, these intumescent white cataracts.
Welcome, Dr. Abdul Latif, sir. In spite of some difficulties, he has joined our session. So welcome, sir. So now I would request Dr. Shihab, my colleague, to introduce our next speaker.
Thank you, Dr. Deshmukh. Our next speaker is Professor Muhammad Mahdi. He's a graduate of Al-Azhar University. Then he got a fellowship in glaucoma for 2 years at the Academic Medical Center, Amsterdam University. That was followed by a doctorate and PhD in ophthalmology. Now he is a head of glaucoma unit and postgraduate education program director at ophthalmic department in Al-Azhar University. He's a senior consultant, founder, and co-chairman of Nile Eye Center for LASIK and eye surgeries. He was a senior consultant and a head of department at Ministry of Health Al-Rustaq Hospital, South Al-Batna till September 2011. And he is a member of prestigious ophthalmic society. His topic today is about phaco nightmares, management of capsular problem during phaco. Prof, the stage is all yours.
Thank you, Dr. Chihab. It is very nice to rejoin the Omani population again for the time I spent in Oman. It was a very nice time that I spent there with such a kind of people, which is so kind and intelligent people, the best people. I have worked with them all over my time. Today, I'm going to talk about phaco nightmares and the management of capsular problems during phaco. Of course, we have to understand that capsular problems, vitreous loss, are inevitable. Even the best surgeon have some complication Broken capsules still occur at a rate between 0.4% and with experienced surgeon, up to 15% for resident in training. So we have to keep this in our mind. So the challenge in cataract surgery is to minimize the risk of complication and to optimally manage complications that do occur, for sure. Okay. Intraoperative complication includes broken capsule, loss of zonal integrity with intact anterior hyaloid, vitreous prolapse, vitreous loss through the incision, retained material as to the complication of the picture. The sequelae of vitreous prolapse, all of us know it, which is so drastic. So be ready before you start, prevent, recognize early, respond early, and then go to actual management. Be ready before you start. Prepare a mental flow chart of maneuvers and sequence of decision before entering the patient's eye. The well-prepared surgeon anticipates potential problems like pseudoexfoliation, through traumatic cataract, pediatric cataracts, failure of complicated cataract surgery, and so many cases included in this list. So keep the required instrument on standby. Here, by the time I went to Oman, it was early 2007, recruited by Dr. Abdul Latif, my best friend. I found that most of the cases is pseudoexfoliation. So I will start with this case now, with which these cases of pseudoexfoliation, we expect that we have a problem of the neurolopathies and the problem of the capsule. So I always stain with trypan blue, then I go to do cataract in the usual way, but the modification here is to try to do not to rotate the lens, the nucleus, in order to avoid zonal stress and to utilize the ergonomics of the phaco tip, the Kilman type, to do a side movement and to assemble the nucleus in its place without rotation and remove 2 quadrants. As you can see here, after division of the nucleus into 2 heminuclei, I do side movement here, utilizing the Ozel ergonomics, and then we divide the nucleus in its place without rotation before removal of the nucleus. So in this case, we exert no stress on the zonules. As you can see here, we are dividing in the same place. Then remove each quadrant separately, as you can see, then rotate the other half simply without exerting any stress on the zonules. Okay, then remove this remaining part, then the case will be completed as usual without any problems. The next case is if we have a case of zonular dialysis. I just discovered this case intraoperatively. What are you going to do? In such case, sometimes we have to notice the incident during cataract surgery and to anticipate the problem and to exactly know how to manage. After doing capsulotomy and I'm trying to rotate the nucleus, I had learned earlier while I was attending a course in India, I have to rotate the nucleus each time. During the rotation, I discovered here inferior temporally that there is some zonular dehiscence here. So I should stop rotating. Then I put on my mind that I have a zonular dehiscence here. I prepared the mental flow chart after division of the nucleus to rotate away from this area of nuclear of dehiscence, then disassemble the nucleus in its place like I did earlier. Then after removal of most of the nuclei, while trying to remove the epinucleus, you find that the capsular bag is to be collapsed. I put it back, then I started to insert the capsular tension ring before removal of the epinucleus or in the cortex, which of course makes removal of the epinucleus and cortex very hard, especially in these cases. So after insertion of the capsular tension ring, I tried later on to remove the epinucleus with gently using the phaco handpiece. After this, with so many visco maneuvers, I tried to, here we do visco expression of the epinuclear material to make it a little bit separated from the cortex or the capsule. Then we remove it and completed the cases. And this is the case at the end. If you can see here, after complete removal, then the IOL is inserted without any problem, as you can see here. The next case for sure is the pediatric cataract cases with its capsular problems. For this case, we have to understand that we have a very elastic eye which tend to collapse and tend to collapse. The problem for capsulotomy, if you want to do a proper capsulorhexis, we have to avoid lens doming and we have to compress the lens and keep it flat most of the time. Here, I open the eye, stain the anterior capsule, then I puncture the anterior capsule with an insulin syringe, as you can see here. Then I used the rectus forceps and I tried to do a capsulorhexis, and you could see here that it tends to go to the periphery. That's why every now and then I inject viscoelastic, probably heavy Helon here. Then after complete, even by the end of this one, I tried to complete it. It is going to do a spiral movement, as you can see here, and the last piece is not going to be cut. That's why I refilled the eye with viscoelastic after trying to get it in. Then after completing this one, you can see here, I refilled, because of I refilled with the viscoelastic, then I completed the rhexis, as you can see here, to get a safe anterior capsule for this case. Now it is finished. Then I did remove the nuclear material after hydrodissection, aspiration, then injected air. You see that even injection of air, the eye get collapsed and the posterior capsule bulged into the anterior chamber. So we have to inject air, stain the posterior capsule with trypan blue, leave it for a while, then fill the eye with viscoelastic again. And then I'm trying to do a posterior capsulorhexis. I punctured the posterior capsule with an insulin syringe. Then I used the vitreoretinal. Then I injected Helon through the opening to separate the posterior capsule from the anterior vitreous face in order not to allow for the vitreous to come into the picture because it's complicated. Then I use the vitreoretinal forceps to do the capsulorhexis posteriorly. And you see it is very fine and thin capsule here. After completion, I did a limited anterior vitrectomy. After completion, I did a limited anterior vitrectomy here. Then I filled the capsular bag with viscoelastic, inserted the IOL and hydrophobic acrylic single piece IOL. And you could see here these two edges of the anterior capsule, and this is the posterior capsule in a very nice case. Of course, I have to close all the wounds. For the intumescent cataract, I have nothing to add after Dr. Rajendra Prasad explained explicitly what's going, but I want to add just two things. It is the timing when you interfere in these cases. If you want to escape the complication, he adds that the configuration of the opening is very important, and I add also that the timing, everything should be ready to aspirate and decompress the intralenticular pressure. So before opening the anterior capsule, you should have an empty syringe on a Helon cannula. After you just do the puncture, very quickly, just remove the escaped fluid here, get out aspirate the fluid, decompress, and keep the lens flat, not doomed, as you can see. As you can see here, it's very important to do that. Then after this, we can do the rexes in the usual way, and then we complete the case. The other case, if you develop the other time, I asked the nurse to prepare this needle. By the time I did my first puncture here, I asked the nurse, where is the syringe? It was not ready. By the time I'm waiting, you could see here that the capsular bag intraventricular pressure is high, and it is expanding by itself, and you have to adopt a technique to rescue this one. So many things here, and I will not add that much here, but I will see that it's not always important to do a continuous curvilinear capsulorhexis, but you could do impart some can opener techniques, and at the end, after removal of the nucleus, you could see after insertion of the IOL that the bag is okay with no problem, and the lens is inserted inside the bag. The other cases is if you are doing phaco, after doing phaco, rhexis, and hydrodissection, during sculpt here, after removal of the epinuclear material here, during phaco, I discovered that some area is shiny a little bit here, which was so suspicious for me. That's why I waited for a while. Then I divided the nucleus, and I rotated the nucleus, removed all the nuclear fragments. After removal of the nuclear fragment and before removal of the cortex, I revised the situation, but keeping in mind that I have something defective here superiorly. So, as you can see here, to assess the suspected area, I found and fill with viscoelastic all the time. The most important here is to keep the eye filled with viscoelastic before escaping out. Here we have to remove the epinucleus and cortex away from the area of suspected problem inferiorly, because the superior part is the affected one. And after removal of the this one, we have to re-inject. You see this is a hole here. Then we removed the cortex. Then the remaining part of the cortex, we can remove it with a white bore cannula, the one used for injection of missile, after, of course, injecting a viscoelastic to just keep the posterior capsule and prevent enlargement of the posterior hole. After I removed the cortical material with the dry aspiration with the cannula, you could see here, I inserted the IOL without any problem, as you can see here, and IOL in bag without any escape of vitreous into the AC, and everything's okay. The other case is if you have a moderate posterior capsule tear during quadrant. After we do rhexis and in the usual way, then hydrodissection was not complete, and while trying to remove this one, after removal of part of the anterior cortex during sculpt, something happened here that leads to sudden loss of anterior chamber pressure, as you can see here, after division of nucleus and the rotation of the nucleus. You see the anterior chamber collapsed here. So I kept in foot pedal position with just irrigation, escaped with the second hand instrument, injected viscoelastic before going out of the eye, then assess the situation. Then I tried to rotate and remove. During removal of the nuclear fragment, I discovered that I have here a posterior tear which is large enough and eccentric. I always fill the eye with viscoelastic to decompress and to prevent posterior displacement of the fragment. Then I removed the cortex and the epinuclear material away from the area of the wound. Then I finish this one. And of course, every time before escaping of the eye, you have to inject viscoelastics. The last part to play with is the part which is the problematic part here. Then later on, I do anterior vitrectomy here. Of course, it is not possible to insert in the bag IOL because the tear is so large and it is eccentric, as the IOL might go posteriorly. The ideal here is to insert a 3-piece IOL in the sulcus, but it was not available, and I inserted a single-piece hard lens in the bag without problem for such a case on the anterior capsule. And then I did anterior vitrectomy after insertion of the lens. The last case to display is the large posterior capsule tear before nuclear removal that was managed with levitation. I didn't mention posterior levitation through the pars plana, but here it was, I think it was iatrogenic, trying to rotate the nucleus before complete hydrodissection is very dangerous. So after division of the nucleus, I find it is difficult to divide and difficult to rotate. So it is an ominous sign that there's something happened in the posterior capsule. Then after trial to division, then I tried to phaco and remove the part of the, I find that something is moving here. So it's the vetus prolapsed into the anterior chamber even before removal. Here, I kept everything in its place, and I went through the hole in the posterior capsule, injecting viscoelastic and elevated the nuclear material on the tip of the cannula, and I used it as a fulcrum. And then I rotated the nuclear material inside the eye over the tip of the cannula, and then I did phaco as usual. Then every now and then I inject viscoelastic through the cannula in the side board. Then I completed the phaco, as you can see here. Then at the end, I injected triamcinolone acetonide, did complete anterior vitrectomy, and assess the situation. Here, the last piece, I use the hydraulic force of the viscoelastic to remove the last piece of the nucleus without losing any particle into the vitreous. Then phacoed the excess vitreous inside the eye. Could be pushed posteriorly a little bit with the viscoelastic, but we have to completely clean the anterior chamber and the pupillary part from the vitreous by injection of triamcinolone acetonide. Then at the end, I assess the integrity of the anterior capsule, over which I have to put an IOL, and I found it's completely normal, but this is a big capsular tear, and you see that part of the triamcinolone escaped posteriorly. Then I inserted the IOL over the capsular bag. Thank you very much for your kind attention.
Very important topic with you showed very helpful tips, especially for starting surgeon. Interesting range of cases and great videos. It was a very informative lecture. Our next speaker is Dr. Khalid Ibrahim Aish. He is a consultant ophthalmologist, cornea and phacosurgeon with special interest in refractive surgery and keratoconus management. He is a director of Dar al-Hikmah Eye Clinic and works as a consultant ophthalmologist at Eye Specialty Hospital in Amman, Jordan. His topic will be phacoemulsification in the presence of iris mass. Dr. Khalid, the stage is yours.
Thank you very much. I'm very happy to present at this Muscat International Ophthalmological Conference. Thank you very much for the invitation and for giving me the chance to present my talk. I will start sharing my screen. My talk is emulsification in the presence of an iris mass. This is a 72-year-old male patient who is diabetic, is complaining of decreasing vision in his left eye, which is the only functioning eye. The other eye, the right eye, was weak since childhood. The patient was planned for a left cataract surgery abroad, but he was deferred many times because of the risk of the surgery. His best corrected visual acuity was 1 foot in his right eye and 3 meters in his left eye. He has a very dense nuclear and posterior subcapsular cataract in his left eye. And he has, as we can see here, a large crescent-shaped fluffy mass in the anterior, in the pupillary area. It looks like a mass extending from underneath the iris. It's avascular. It's not vascularized mass, but it's a large mass in the temporal part of the extending from 1 to 5 o'clock. And this is what the patient came with him as an investigation. He has underwent abroad. He has an OCT imaging. As we can see that there is a mass here, but this OCT does not show the whole configuration of the mass. So it came to my mind, is this a simple cystic lesion, or this could be a melanoma, ciliary body or iris melanoma, or this could be a vascularized lesion that could bleed during the surgery. So I was not sure about the origin of this lesion, especially this is a one-eye patient, and we should be careful before doing the surgery for this patient. So what are the possibility of masses? According to Carol Shields, she mentioned that the 6 most common iris lesions that a comprehensive ophthalmologist might see are 1 is a freckle, 2 is light lich nodules, could be nevus or melanocytoma, or a melanocytosis or a melanoma. But she didn't mention anything about cystic lesions, because as we know, the differential diagnosis of iris masses could be cystic or could be solid lesions. Cystic in the form of primary iris pigment epithelial cyst, or a primary iris stromal cyst, or could be an epithelial downy growth, or a solid lesion, as we mentioned, the melanocytic lesions. So I was suggest that I should consult our ocular oncologist, and my friend Dr. Yaqub Yusuf is an excellent ocular oncologist at King Hussein Cancer Center. I called him, and he told me it's better for him to see the patients and to do a UBM for him. So I sent him the patient, and the UBM was done for him. And as we can see here, this is the cornea, this is the iris, this is the cyst here, but also we can see that there is another small cyst in the other part, and we can see the difference between the UBM and the OCT, where the UBM can give us a much more detailed and a more deeper penetration of the lesion, so that we can see the whole lesion and know what exactly is going on. And also, what was noticed that also the patient has another lesion on the other side of the iris, but it was behind the iris. So the oncology report came that this is a simple iris cyst that is extending to the pupillary area, and it has no impact, but also there is a nasal and temporal ciliary body cyst. And he recommended that there is no biopsy is needed, as he was sure that this is just an iris cyst. So if we review the literature about which is better in such cases, UBM versus OCT, we can find that the anterior segment OCT is superior in a small iris lesion that are confining to the anterior iris, while the B-scan is a better imaging for larger iris lesion with a posterior extension, as our patient is. And also, Hewitt et al. Suggested that OCT can be used in minor iris tumors with low degree of pigmentation, but UBM is suggested for iris and ciliary body lesions with heavy pigmentation, as our patient is. So now we are sure that this is a ciliary body, is an iris cyst, but what are the association that we could have with iris cysts? They could have angle closure glaucoma, could have the toe iris syndrome, as our patient has, and was obvious with the UBM and the OCT, but his IOP was normal. These patients are at risk of pigment dispersion syndrome. They are at risk of lens subluxation, and we should keep this in mind before planning the surgery, so as to have planned for this. And also, these are at risk of iritis, especially if the cyst ruptured and can bring us an inflammatory reaction in the anterior chamber. So we decided that we need to proceed because this is the only eye and this patient is almost blind. The first step was I was not sure if I can doing a good sized capsulorhexis because we are facing with a hard cataract. But once you can see when we inject, I used a heavy viscoelastic material. I used the Viscot, but we can see that the mass start to moving away from our rhexis side. So I proceed with the capsulorhexis in a normal fashion, and I kept injecting a viscodispersive material to push the cyst away from the, as we can see here, from the area. And I completed my capsulorhexis. It's a good sized capsulorhexis. Then I proceed with the hydrodissection, but as we can see, it's a large nucleus and it's a hard nucleus. So I proceeded with the phaco emulsification, and then I tried to rotate the lens, but it was not rotated easily. So I shifted to the chop technique. I fractured the nucleus into 2 halves, and then I aspirated into and kept phaco emulsification into the pupillary area. It was a huge and it was a hard nucleus. And I kept putting viscoelastic, heavy viscoelastic to protect the cornea. But also, if we can keep watching on the iris cyst, it's keep floating in the anterior chamber, but it's away from the phaco tip until here. When I try to take this piece here, you can see that I hit the iris lesion and it was opened. But I managed to complete my phaco emulsification normally. And at the end of the phaco, now I proceed to the irrigation aspiration, and I cleaned the cortical material. Then I inserted the eye oil in the bag, and everything was fine. And the mass is still here, but you can see that this is the phaco at the end of the procedure. Sorry. So this is the patient the second day. As we can see, there is some corneal edema. It was a hard cataract, but he has a vision of 6/18 second day. And the mass was not seen, maybe it's behind the iris, as the fluid was aspirated from the lesion. So the take-home message in such cases that preoperative evaluation is a very crucial step. And when in doubt, always consult the ocular oncologist. They can give you a better idea about what is going on. And in such cases, UBM is the golden standard machine to diagnose such cases. And sometimes you need to take risky decisions when it comes to solving patients' problem, and you need to do what is needed. Thank you very much.
Dr. Khalid, very interesting case.
Thank you. I will stop sharing my screen.
Now, our last speaker is Dr. Deshmukh Devdatta. He's a gold medalist from Mumbai University and completed a fellowship from the prestigious Shankar Nagaraya in Chennai, India. He's presently working as a senior phacosurgeon and a medical retina specialist at Ophthalmology Center in AFH since 2006. He has presented various papers at national and international conferences, and he has publication index peer-reviewed journals. He is assistant faculty at Postgraduate Oman Medical Specialty Board. He is a reviewer of for Oman Medical Journal of Ophthalmology and a peer-reviewed open access journal. Is also an active member of Oman Ophthalmic Society and All Indian Ophthalmologist Society. He will be presenting today about cataract surgery in keratoconus. Dr. Deshmukh, go ahead.
Thank you, Dr. Shihab, for those kind words. Let me present today. My topic is cataract surgery in keratoconus, pearls and pitfalls. It is about a middle-aged lady which I operated recently with a moderate to severe keratoconus. Let us come to the case. She was 39 years old, lady, known case of keratoconus. We were following her since about 3 years. Earlier, she was using contact lenses, but recently she stopped using it because she developed right eye keratitis. Initially, she presented with a gradual diminution of vision in more in left eye. There was no family history of keratoconus, and she was not having any history of eye rubbing or a steroid use, and collagen cross-linking was not done for her. Initially, she came in January 2021. Her visual acuity in the right eye was 660, which was improving to 69 with almost -6 diopter of astigmatism. While in the left eye, it was 3/60, improving to 6/24 with -3 diopter of astigmatism. There were early cataractus changes. So we told her about the condition, and she told she will think about the surgery and come back to us. Later, she came in September 2021. Her visual acuity dropped further. It was 618 in the right eye and 3/60 in the left eye. In the right eye, she had a grade 1 nuclear sclerosis, and as I said earlier, she had an paracentral superior nebula. In the left eye, it was NS2 with a cortical grade 4 and a PSC of grade 2. So thorough counseling and pre-assessment was done for her. As keratoconus was stable over years, we gave an option, her an option of regularizing the cornea with a topo-guided PRK, but she was not very keen. And finally, she said she will go for a cataract surgery directly, and she was willing to use presbyopic glasses in case needed. So after this marathon discussion, we went for an, we decided to go for an femto laser assisted cataract surgery with a toric IOL for her. This was her pentacam. As you see, the keratoconus was quite advanced in the right eye with a Kmax of 54.3 in the right eye and 49.4 in the left eye. As you can see in the right eye, there was a bit of flattening superotemporally, and this area was thinned out because of the earlier scar. I obtained Holaday EKR report. I just saw just to confirm the axis of astigmatism. Her corvis was, of course, way abnormal. This was her IOL master report. We have an IOL master 400, which showed axial length of around 25, more than 25 in both eyes. So she was a bit on a myopic side. And you can see the cylinder was quite high in the right eye, and it was -6.62, and in the left eye, it was around -3. But the best part was that her topographic astigmatism and the manifest astigmatism were quite corresponding. So I went ahead with Barrett's 2K toric calculator, and I targeted around -0.5 in the left eye, which we operated earlier, and around -1 in the left eye. So finally, she underwent both eyes Lensex cataract surgery with a toric IOL. We did her left eye first, followed by the right eye. Surgeries were uneventful, but we were pleasantly surprised to see her refraction at 1 month. We told her initially before cataract surgery that she may need to undergo future procedures, or even she has to use contact lenses or the glasses post-operatively. but I was quite surprised to see her unaided vision of 6/6 in both eyes, and even in fact her near vision was N5. So probably this has occurred thanks to her high coma, and autoref did not show any significant astigmatism. It was showing astigmatism of minus 0.75, but she was not accepting any cylinder as such. So she was extremely happy, and we were lucky to have such an excellent result in such a complicated scenario. But as you know, this may not happen in all cases. So why I'm saying so? Let us see why. So what are the challenges in such cases? And we have to address these issues in any case of keratoconus with a cataract. We have to see first the stability of the keratoconus, whether there is any need for collagen cross-linking, and whether we should regularize the cornea with a topo-guided PRK or an intracorneal ring segments. Then we have to determine the patient's future visual needs, whether we are anticipating any use of contact lenses for the patient, or in case of severe keratoconus, is there any need for future keratoplasty. Then comes the biometry challenge, and of course IOL selection, whether we should go for a spherical or a toric lens. And lastly, we have to anticipate the use of post-operative contact lenses or glasses, or we have to deal with refractive surprises. So this is a simple decision tree. As I mentioned, any case of keratoconus comes to us with a cataract, we have to first see a best corrected visual acuity. In case of grade 1 or grade 2, when the best corrected visual acuity is good, then and at topography showing more than 1.5 diopter of astigmatism, we can go for a toric IOL. In case astigmatism is less, we can go for a monofocal IOL. As you know, in grade 3 or grade 4 keratoconus, the first question we have to ask is whether corneal shape can be improved by topo-guided PRK or intracorneal rings. And when this is done, then we can go for a either toric or a monofocal lens. Dr. Jarade has come with a similar algorithm, whereas he mentioned about the correspondence of manifest axis, cylindrical axis, and the topographic axis. If it is corresponding, then toric IOL gives the best results. Of course, in cases of advanced ectasia, we have to deal with that case with a triple procedure in the form of keratoplasty and of course cataract surgery. So how the biometry challenging in such cases? As you know, keratoconus often ends with a hyperopic refraction after cataract surgery. This is because of irregular keratometry, which leads to overestimation of corneal power, leading to underestimation of IOL power. This is similar to post-myopic refractive status. Secondly, as you know, posterior cornea steepens along with the anterior cornea in keratoconus. So this decreases the anterior to posterior curvature ratio in case of keratoconus. One more differentiating factor is the effective lens position, which is more posterior in case of keratoconic eyes. And lastly, the corneal multifocality and the tear film irregularities also restrict the repeatability of the corneal measurements. So this adds to additional source of error. Is there any perfect IOL calculation formula? So the answer is no. There are n number of papers trying to answer this question. So I'm just showing you 4 of them, recent papers. Let us go through them. The first paper, as you see, that shows that SRK2 formula may provide most accurate IOL power calculation in mild keratoconus, but there is still no consensus in cases of moderate to severe keratoconus. As well as per this paper, all formulas lead to hyperopic refractive outcome, and they have found out as SRKT as the best IOL calculation formula. Whilst this paper in an American Academy of Ophthalmology shows that Kane keratoconus formula was the most accurate in this series of cases. While this paper shows that Barrett's universal 2 formula was most accurate in mild to moderate cases, and then they have advocated pentacam keratometry to help and improve the outcomes. So as you say, there is no still consensus in moderate to severe cases. So what was my approach? Thanks to Dr. Mazen Sinjab, who always helps us in finding out solution in such complicated cases. I'm proud to be associated with Sinjab Academy. So he has given a simple algorithm in such cases. In case keratoconus is mild, we can go for an EKR values and the axis with a SRK2 formula, but always compare that with Barrett's 2K formula and a Kane formula. In case of, as I said, in case of moderate to severe keratoconus, there is still no agreement, but we can always go for a Barrett's 2K calculator along with the Kane's formula, and always target for an post-operative post-operative refraction as -1 to -1.5. So how about IOL selection? Of course, avoid multifocal IOLs because loss of contrast sensitivity with these lenses will be magnified by corneal irregularity. Most patients with keratoconus has high negative spherical aberration. So a true aspheric lens or even a positive spherical lens is preferred in such cases. Use of toric IOL is a good option if the cornea is stable or a keratoconus is stable over time and astigmatism is very regular as in our case. And as I said, the topographic astigmatism if it is corresponding with the manifest astigmatism. And if the patient is not wearing a contact lenses. Of course, in severe keratoconus with very irregular cornea, or the post-operative contact lens is anticipated, we should go for a monofocal lens. How about operative technique? Whether we should go for any modification? There are few points. Incisions are best placed away from the thinnest area of the cornea, and the main incision is better sutured to reduce the surgically induced astigmatism. Few surgeons do advocate scleral tunnel incision in such cases. Of course, we have to avoid LRI in case we are going in for the flax, as in our case. Use of intraoperative aberrometry can be debated whether it improves the post-operative outcome. It's a question. Always ensure a proper centration of monofocal IOL to avoid inducing trauma. And of course, thorough washout of viscoelastic is advocated to avoid toric IOL rotation. So to summarize, topographic irregularity of anterior and posterior corneal surfaces, altered refractive index, and a regular thinning all combine to make cornea a key factor in IOL power determination in keratoconic eyes. Keratoconus adds to complexity of cataract surgery, but there are methods and approaches that can help to improve the outcomes and patient satisfaction. And toric IOLs can provide excellent outcomes in carefully selected patients with a non-progressive keratoconus. Thank you so much.
Dr. Deshmukh, very informative talk. And let me just check if there is any questions.
Yeah, you can see in the chat, Shihab, there are a few questions. If you won't mind, can you just go through it?
I have a small question, if you allow me.
Go ahead,
Yeah.
Dr. Khalid.
Yeah, thank you. Dr. Arub, please. Is there still a role of extracapsular cataract in managing cataract? After your talk, you showed that very hard cataracts, you still manage them with phaco's. What is the role nowadays of the extracapsular cataract?
So, as I mentioned, old techniques are not to be ridiculed. Extracapsular surgery held sway once upon a time. But today, I will still do extracapsular cataract surgery, but it is not the large incision. It is the manual small incision cataract surgery. If I'm dealing with a very, very elderly patient, a very shallow anterior chamber, a corneal status is not very good, a deep socket, uncooperative patient cannot lie down for a long time, dementia. So those cases, I'll go for a manual small incision cataract surgery, make an incision is about 7 or 8 millimeters scleral tunnel. But those cases are very restricted most of the time with the better phaco machines, and it is just a question of self-belief. I mean, if you follow the right principles, if you follow the right phaco parameters, and be patient, and usually things turn out pretty well. But yes, there is definitely a role for manual small incision cataract surgery in situations or indications which I have just mentioned.
Thank you.
One more question for Dr. Arup, sir. As you know, the very hard and brown cataracts, they come with an posterior plate, which is very rubbery and difficult to separate. So, what is your best strategy in such cases?
So Devdatta, thanks a lot for asking this question. I mean, I have been doing these cases for the last 25 to 30 years with standard machines earlier, and now higher end machines and intermediate machines. So what we have realized is one technique fits all does not work out in these cases. I mean, if I go for a direct chop without sculpting, it may work out in certain cases, it may not work out. So my strategy basically is to make a crater or make a tunnel as deep as possible, going almost close to the posterior nucleus plate, and then start the chopping. The chopping starts in the periphery, so then you see the chop line, and then you use a step-by-step chop in situ. Just bring the chop line gently closer and closer to the center, and sometimes it requires manual separation between the phaco tip and the chopper, and then you separate the fibers and tease out the fibers and bring it to the center. So I think the most important thing is to go as deep as possible. If you feel that the chopping is the posterior nuclear leathery plate is bothering you, maybe one can go in for a little more chopping, little more sculpting with the appropriate phaco power, go a little deeper, sculpt a little bit more, and then start chopping. And most of the time it does work out. It is basically just go with the flow, see how the case is going, and adjust your surgical technique and phaco parameters depending upon that.
Okay.
But I would not advocate a direct chopping for that without, if it is a brittle case, fine. But if it is not a brittle case, in that case, you'll have a very good chop, but then it will stop at the posterior nuclear plate. It will not go beyond that. And then you're left with a big messed up chunk of nucleus material within the capsular bag, and then at times it may be difficult to handle that situation.
Right.
Dr. Deshmukh?
Yes, sir.
Yeah, I have a comment. Of course, all of us are not that much clever like Dr. Arup is and Dr. Prasad for sure. For the hard cases, I think that phaco is not a target by itself. The target is to get a safe surgery with good results. I think, and most of our cases, usually for the hard cases, you have some corneal problems as well. So the safest here is to do some kind of small incision, manual small incision cataract surgery, and I always do that for hard cases. I never go for hard case with some compromised cornea. I never do phaco, and the best for it is to do manual small incision, and also because simply we don't have the protective shell of the epinuclear material. All the nucleus had been transformed into one mass. So and the edge is very sharp, and in case of one of these edges touches the posterior capsule, it might open it, despite the fact also that we might have some zonular problem in these cases, which the same applies also for intumescent hard cataract. Intumescence, there's two cases. Intumescent hard cataract, there's no any protective shell for the posterior capsule, and it is very easy to get it in less than 5 minutes through manual small incision. Of course, the honor is for the Indian that invented this technique, and I learned it from them, and it is very safe technique and very cheap as well for the patient.
I agree with you, sir. The surgeon is the best judge. He must employ the technique that works best in his hands. and whatever he does, it should be in the patient's best interest.
Yeah, very true. I will agree on this point. As you said, in this part of the world, in Gulf countries, we have seen corneas are not that clear as we see in Indian scenario or somewhere else. So even I am operating here since 2006. So usually, as you said, in case of very hard and brown grade 5 cataracts, we do go ahead with a safer option like a SICS. True. That's
You
true.
know, by the time I was in Oman, the first few weeks, I was going to the OT like I'm going to jail, because I see all the cases something like pseudoexfoliation, and it's very hard. In Egypt, if we saw a case of pseudoexfoliation, we bring our friend to see, because it is something like history. But in Oman, it was very, very large numbers, and they have to deal with this. But actually, the kind of pseudoexfoliation, exfoliation in Oman is totally different from what we have. What we have in Egypt, what we have in Egypt is, what we have in Egypt is real pseudoexfoliation. In Oman, I think it's some sort of true exfoliation, and zonulopathy is not that much as what we have in Egypt. And zonulopathy is totally different than what we have in Egypt, which is true exfoliation in Oman, and zonulopathy is not that much.
True. On this point, one more question. In case of pseudoexfoliation, if there is no obvious, zonular dialysis or this one, zonular dehiscence, do you recommend using this one, capsular tension rings, in case there is a severe pseudoexfoliation and you want to protect the posterior capsule or an instability?
It depends on how much zonulopathies you have. If you have too much zonular dialysis, for sure it is not possible to put such a case, except if you are going to fix it, because it is a degenerative process and it might go completely posteriorly with the bag, with the tensioning you are going to put. But if you want to have just support to the capsular bag, which is not dialyzed for the pseudoexfoliation syndrome, you could put it there.
Sure. Arup sir, any comments on this point?
I was little, there's a message. What was the question?
In case of severe pseudoexfoliation in a hard cataract, do you go for an CTR in all cases, or if there is zonular dehiscence, then only you go for?
No, I do not go for a CTR as a routine. So once upon a time, whenever I had a patient with pseudoexfoliation, I was using a CTR. All right, and then it was I think maybe about 15 years or 12 years ago. So now I use a CTR only if there is a zonulopathy.
Okay. One question for Dr. Rajendra Prasad. Are you using, if at all we want to use an simple sewing needle, then how to handle it? I mean, because there is no handle, then how can we use it after sterilization?
Yeah, after the simple sewing needle, like as I told you, like you take it, hold it with the needle holder, the locked needle holder. So you have a locked needle holder. You hold it with the locking needle holder, which is called as a conjunctival suturing needle holder.
Right.
And hold it with lock it, and then turn the tip, and then you can use with that forceps itself to puncture. That is what I am doing now at present. But now actually you have because recently I have come across, you call it as a pencil tip spinal needles. You must have seen like pencil tip spinal needles. So these spinal needles, they come with a syringe, like a normal needle, like a hypodermic needle. So you can fix it in the syringe and then you can use it to puncture. So that I have started now recently using that spinal needles, very good spinal needles, very sharp tip. And another important facility with the spinal needle is it has a hole also in it, so that you can aspirate also. When you puncture it, you can aspirate also. like we do the small needle puncture and aspiration. So you puncture with the spinal needle, you get a hole, and then you can aspirate the fluid also if it is required. But you just puncture it and come out, and then the fluid will automatically come out of the capsular bag.
Okay, so their configuration is a round like a sewing needle.
Yeah, definitely, because the configuration of the spinal needle, it's called as a pencil tip spinal needle. Spinal needle, they don't use the hypodermic needle to puncture the spine, no? When you're giving the anesthesia. So it's a spinal needle, different needle. It's a round tip, pointed round tip, spinal needle, similar to sewing needle. So that also is very good option. But if you want to use, but these are little expensive. But if you want to use the simple sewing needle, it's very easy. Like you just hold it with the locking forceps, and then you can use it to puncture the anterior capsule. It's very simple.
Great. There are no more questions. I would request Dr. Abdul Latif sir to say a few words. So you are muted.
Okay.
Yeah.
Is that okay?
Yes, sir.
Yeah. I'm really thankful and grateful for all the speakers. And I apologize for my being unable to join right from the beginning, but I really enjoyed all the talks, and my great regards and respect for all of them. And I really made use of the new techniques of all the speakers. And I wished I started with earlier to say a few words at the beginning, but anyhow, thank you very much. It is interesting really to hear. I'm currently not doing any surgeries. I'm retired. I may start after some time in the private. But I really enjoyed hearing the new innovations and new techniques and new ideas and innovative ideas which have been put forward in all the talks of the colleagues. So I repeatedly thank you very much, everybody, and hope to see you in the future, inshallah, face to face, which you have already missed now to join. So thank you very much, and see you inshallah next year. And thankful all the team who organizing committee headed by Dr. Rajid Saidi for the great work they have done, and thank all. Thank you. Goodbye.
Thank you, sir.
Thank you very much, sir. It was really nice meeting all of you.
Thank you
very much. It was very nice talks. Thank you all.
Thank you all for your.
Thank you all. Thank you, Dr. Abdul
يعطيك العافية دكتور عبد اللطيف.
أهلا بك. شكرا جزيلا.
السلام عليكم.
It was nice to be with you, all of you.
Thank you.
Thank you very much.
السلام عليكم.
السلام عليكم.